So I'm Sophia, and it's nice working with a lot of you this month. Thanks for having me in the Echo Lab. And I'll be presenting on using PoCUS to help diagnose and manage shock in critically ill patients. So the objectives are to develop a practical approach to assessing shock at the bedside using PoCUS echo in sick patients, to understand limitations of using PoCUS to assess these shock states, and in particular to recognize and assess for dynamic LVOT obstruction as a potential cause of shock using PoCUS. So really, over the past 20 years or so, there's been a great decline in the use of PA catheters to help manage shock in general ICU populations. So not talking about, the cardiac surgery population or special populations like lung transplant or pulmonary hypertension.
Good morning.
Good morning. But in general med-surg ICUs, we have really stepped away from using PA catheters due to data showing maybe it doesn't improve outcomes, and there may actually be increased morbidity and complications from routine use. And therefore, we've increasingly moved to using echo and PoCUS to help us manage patients who are in shock. However, the challenge with this, even though echo and ultrasound and PoCUS have been developing over the past few decades, is that there's actually great variability still in our training nationally and globally. And even at this point, not a very great consensus on what is adequate training. So just for example, as an ICU fellow in Canada currently, the recommendations are to get around just 30 cardiac scans. And the recommended ranges for ICU training is quite varied globally. In countries that do have a national curriculum, they recommend somewhere between 10 to 100 scans, which is really, quite varied and also not very many for us to learn this competency. And there's practical considerations. So in critically ill patients, we often need to make decisions rather quickly. In these patients, we often have suboptimal windows, can't get great pictures, they're ventilated, they can't lie on their sides for you, they can't hold their breath. And again, training levels vary very considerably. So therefore, we need to learn a focused, relatively simple exam, a PoCUS echo exam, to use in these clinical situations. So really, what I'm trying to do is try to figure out a framework to see how can I obtain the information I need using PoCUS to help assess why this patient may be in shock in about 10 minutes or less. So this is not really a comprehensive talk about all the different methods to assess these measures, but really picking out some select techniques that I think we can learn in a short time frame or relatively short time frame to at least help us through this diagnostic process. So just a quick reminder, shock, many different causes, a life-threatening state of acute circulatory failure that results in inadequate cellular oxygen utilization at the end of the day. Different causes of shock can be broadly categorized into these 4 class categories. So distributive shock, which is mainly septic, which is probably the vast majority of what we see in general med-surg ICU. There's cardiogenic shock, of course, from many different causes, hypovolemic from either fluid or blood loss, and then obstructive shock, such as PE, tamponade, or tension pneumothorax. And again, there can be mixed causes of all these shock states. And increasingly, even in the CCU or CVICU population, you may see patients who initially look like they have a cardiac cause, but maybe they do have something else mixed in, like sepsis or like a PE. So just to go into quick ways of assessing. So starting with the LV systolic function, I think most commonly in the ICU, we either use Simpson's biplane or visual estimation. So I won't go into, of course, great detail about these methods, but Simpson's biplane, as you all know, there are some major limitations, especially in the ICU. It's easy to foreshorten the view, easy to get inaccurate measurements. It is hard enough to visualize endocardium in the echo lab, but especially in the ICU, we don't use ultrasound enhancing agents. We often have poor windows. It can be really, really hard to see the endocardium properly, and therefore can be quite difficult to measure this. And then practically speaking, I'm often trying to do this on a little PoCUS machine. I don't have a mouse, I don't have a computer, I don't have the proper software, and it can be really quite challenging. I don't know if my measurements are reliable in this case. So therefore, we often just rely on visual estimation or eyeballing the ejection fraction. And there have been studies maybe suggesting that eyeballing can be an adequate, definitely not to report a formal echo, but at least to get a sense of what the ejection fraction is.
Okay, it's still the most commonly used method to assess LV.
Yeah. Okay, perfect. Dr. Lianpo is saying still the most common method to assess LVEF, which I'm glad to hear as well. It's the eyeballing it. And then this is a study from quite some years ago now that compared observers who range from echocardiographers with level 3 ASE training with fellows who had 2 months of ultrasound training. And they actually found that maybe eyeballing it is adequate in a lot of cases. This is just the reference ranges for other presentations, or if I give this again, for the cutoff values for EF as per the ASC. And then a lot of times, as you mentioned, measuring the EF can be difficult, but also in the shock states, for me, determining someone's cardiac output may be a lot more important than knowing what the actual EF is. As you all know, we're trying to see whether the heart can deliver enough oxygen to the tissues in these shock states. And certainly you can have patients with a low EF who are not in shock, like many patients with heart failure with reduced ejection fraction who are walking around as outpatients doing just fine. And so really when I'm trying to quickly assess what the cardiac output is, I use the LVOT VTI in the ICU. Just a quick review of the cross-sectional area and basically the measurements you're trying to obtain for the VTI. This is another reference slide. So you're trying to pulse the LVOT in the aortic 5-chamber view most commonly. And the VTI has been validated as a good surrogate for stroke volume with the ASC guidelines and other papers I've seen using a lower cutoff of around 18 or so as approximately the lower end of normal for stroke volume. If you're measuring the RVOT, that's a different cutoff, which I've seen around 15, but I think most commonly we try to do the LVOT. And in the short term, often we can just follow the VTI alone, especially as a monitoring parameter to see our responses to our interventions like fluids or pressors, because in the short term, the LVOT diameter does not change. So sometimes we can just measure the VTI if you can't get a good LVOT diameter measurement. There are limitations, of course. Probably the most common is, especially for us in the ICU, is image acquisition errors or perhaps just not enough experience as for user proficiency. You can get an incorrect angle, you may underestimate the VTI, you may not be actually measuring the peak velocity, maybe making errors like mistaking the MR jet for the VTI. As mentioned, small inaccuracies in measuring the LVOT diameter, because it's a squared equation, can lead to pretty big differences in our cardiac output calculation, which is another reason why sometimes we just track the VTI by itself. And then this method also assumes laminar flow. So it can be inaccurate in different situations, like if a patient has aortic insufficiency, subaortic stenosis, prosthetic valves, or LVOT obstruction from other causes. And in our patients who are not in sinus rhythm, lots of our patients are in AFib, or they're septic or in shock for other causes. You're supposed to average out 5 or more VTI beats, which I think sometimes doesn't get done because we're doing this in a very short time span. Just a very quick review for the valvular assessment in the ICU. We're not really doing anything really complicated. We're just looking for very obvious causes for why a patient may be in shock or deteriorating. So this is not my imagings, but this is an emergency paper that found critical aortic stenosis on their PoCUS views for a reason for why a patient came in syncopal and in respiratory distress. So we're really looking for very obvious things like severe MR, severe AS at the bedside, and really all we usually do is put the color on it and see if there's anything obvious or not. And we're not often doing measurements. I'm sorry, moving on to the RV. So really, when we're assessing the RV in shock states, most commonly looking for causes of obstructive shock. So the classic, you're thinking of cardiac tamponade, PEs, or tension pneumothoraces, which can acutely increase the RV afterload and cause shock. There are many other causes for RV failure, in particular in our ICU patients, a lot of primarily respiratory issues such as ARDS or acute and chronic core pulmonality from patients who have severe COPD, obstructive sleep apnea, et cetera, can also contribute or cause RV failure. So when I'm looking at the RV acutely, I've looked at a few things, really looking for signs of dilatation. look for paradoxal septal motion, especially in the short axis. And then a few measures to estimate the RV systolic function, mainly the TAPC and the RVS measurements. So RV dilatation, again, most of the time we end up just eyeballing this, reading of the RV, not more than around 2/3 the size of the LV. But officially, if the RV to LV ratio is greater than 0.6, that's what we would call dilated, and it's greater than 1, then we're dilatation. Again, just reference values from the ASC. And because I'm in ICU and I can't remember all these numbers, I really just remember if the basal diameter is greater than 4 centimeters or so in the apical chamber view, I would be very concerned for dilatation. Okay. And the TAPC and RVS prime, both estimates of RV systolic function. So both measuring the RV free wall in the apical chamber view, TAPC less than 17 is the cutoff value I remember, and S prime less than 10 or so can be indicative of RV systolic dysfunction. Different limitations for these measurements. So the TAPC and RVS prime, again, angle dependent. If you're off, you may be underestimating. Primarily, you're assessing the function of the RV base, so it does not really tell me whether the apex is moving well or not. And sometimes there can be challenges in getting a good picture of the RV free wall, especially in the ICU settings. So I may not actually be able to measure these well. Again, in the ICU, we're really looking for very obvious causes of shock. So this is a patient scanned over a year ago, came in with profound hypoxia, hypotension. We're not looking for subtle signs of RV failure, but for the provolone here, the RV is obviously huge and dilated, and probably a ratio greater than 1 to the LV. And this lady ended up having a massive PE, which you can kind of see some clot going forward. So put this probe on, this lady went for IR guided thrombolysis, catheter thrombolysis very shortly after. And okay. So pericardial effusion can be assessed in many different views for the presence of effusion. But probably what's more important for me is to see if I see this effusion, is this hemodynamically significant? If I'm in doubt, I really call cardiology urgently to help to get them to help me assess. But really, I'm looking for signs of whether the effusion is causing high enough pressures to cause chamber collapse, starting with the RA in systole, and then moving on to the RV, and then hopefully not at the point where it's causing LV collapse, but it can happen. There are measures looking at the IVC for IVC dilatation and lack of respiratory variation, as well as an echo pulsus paradoxus. But a good reminder is that these measures are really helpful in patients who are spontaneously breathing, not on positive pressure ventilation, and therefore can be quite unreliable in a lot of our patients who are mechanically ventilated. There are pitfalls when assessing pericardial effusion. So a lot of times, we see an effusion, you have to make sure, is this a pericardial effusion or is it pleural effusion or ascites? So this is a nice picture showing ascites in the subcostal view, which if you're not careful can be mistaken for a big pericardial effusion. Can mistake the pericardial fat pad for an effusion, or sometimes we see an effusion and it's kind of a red herring. It's not actually hemodynamically significant. But again, when in doubt, I would call the CCU for someone to help me assess this. And then just a reminder, there are lots of other circumstances which can make the diagnosis of tamponade more challenging, like in patients or trauma patients who may have low pressure tamponade or post-op patients. So they're both hypovolemic and in tamponade, but they have a small IVC because they're actually bleeding out somewhere. Oh, sorry, this got cut off here because of formatting, but the rest of it said, again, patients who have increased abdominal pressures like abdominal compartment syndrome can also have a small IVC. And the last one was that patients, if they've had core pulmonality, really high right-sided pressures for a long time, they may not develop right-sided chamber collapse until quite late in their disease process. Tension pneumothorax, just briefly, again, you see the signs of right-sided heart failure and dilatation. Hopefully you would have to keep this in mind as a potential cause. And when you're already there, you can do lung ultrasound, which I won't go into great detail, but you look for signs of lung sliding with a linear probe, and often end mode can be quite helpful here. If there's no lung motion at all, you get a barcode sign. And then if you see the lung point, which is when you can actually see the lung sliding in and out of view in an area that has no lung motion at all, that's very specific but not sensitive. And sometimes you can have a chest x-ray, which just shows this giant pneumothorax, but hopefully you diagnosed it already before the chest x-ray arrives. PoCUS also extremely useful to look for hypovolemia or signs of hypovolemia with some caveats. You may see a hyperdynamic LV or a very small collapsing LV cavity. IVC can be useful in some times, but again, with some caveats, which I'll go into. So in spontaneously breathing patients, the IVC, you're expecting to see a small IVC that collapses on inspiration. In patients who are on positive pressure, whether BiPAP or mechanically ventilated, you may not see this even in patients who are hypovolemic, but sometimes you will see the IVC distend with inspiration as the positive pressure is being pushed in, and then you will have a low cardiac output, such as measured in VTI. These are the well-known and established estimates for RA pressure based on the IVC size and the collapsibility. There are some limitations. So the IVC distensibility index in positive pressure ventilation has been described, and the cutoff of 18% is used. But really, if you look at the papers that studied this, they had very specific parameters for the ventilator. So these patients were ventilated at around 8 mils per kilo, respited 15, peak of around 5, and the plateau pressure was kept below 30, which is what we think of as lung protective. Lots of our patients are not on these settings. Lots of our patients are on peaks that are much, much higher than this. Or now we're trying to target even lower tidal volumes, like 4 to 6 mils per kilo. So how applicable IVC dispensability may be in these patients is hard to say. And the IVC is a static measurement. It's an estimate for the CVP or preload, but can be a poor predictor for whether someone's actually fluid responsive or not. And similar to the pericardial effusions, there are different clinical contexts that can impact the IVC measurements and make it less reliable, such as in patients with abdominal compartment syndrome. IVC can be quite small and compressed just because the abdominal pressures are very high. In patients who are in respiratory distress, they can have such a high drive to breathe and such negative intrathoracic pressures that they can collapse the IVC. And pericardial effusion, pericardial disease, and the last line, which is cut off here, sorry, is talking about patients who have things like TR or pulmonary hypertension and make the IVC quite unreliable. Many different measures to assess fluid responsiveness, and still a great topic of interest. So I could spend a whole hour just talking about all of this, but something that you can do quickly, since you're already there with the ultrasound, is do a passive leg raise while measuring the VTI. And a cutoff of an increase in about 12% of the VTI has been well correlated to patients who may respond well to more fluid. There are different algorithms I found in the emergency and critical care literature that try to make it easier for us to have a diagnostic approach to whether someone's in shock or not. And really, both these papers have nice tables that you can, or algorithms you can follow just to have a I guess a preliminary approach at least. It really starts with looking at the VTI to see if there's high cardiac output or not, or a normal cardiac output. If there is, most of the time it's distributive shock. Most of the time, distributive shock is sepsis. You know, if the VTI is very, very low, then you're looking for things like cardiogenic shock. Is there a pericardial effusion? Are you going to tampen that? Is there signs of RV failure, RV dilatation that makes you think of obstructive shock? Or is there signs of hypovolemia? So this is very similar to the mental diagnostic approach I have in my mind when I'm doing PoCUS in the bedside in 10 minutes or less. The challenge with all of these algorithms I found is that they really don't talk about dynamic LVOT obstruction. So dynamic LVOT obstruction is a syndrome that's probably under-recognized in some of our ICU patients because really you need to put the probe on them to diagnose it. It's classically, LVOT obstruction is described in hypertrophic cardiomyopathy in patients who are either at rest or can develop it dynamically, but have now also been described in many other states, including septic shock, septic cardiomyopathy or stress cardiomyopathy, or Takotsubo's, especially the classic apical ballooning phenotype, post-MI, post-valve surgery, and RV overload states. And there are different reasons this develops, but one mechanism is the systolic anterior motion of the mitral valve, which is thought to develop at least in part because of the Venturi effect, though I think the reality is much more complex than just the Venturi effect, which is when there is high flow across a area with a lower cross-sectional area, which creates a high velocity that then has this drag effect and pulls the mitral leaflet into the LVOT. So it's much more complex than just this. Also depends on the shape, the geometry of the septum, the mitral valve position and orientation, the aortic valve orientation, etc. And there are predisposing conditions. So some patients can have LVOT gradients or obstruction even at rest, or others can develop it dynamically. You can have anatomy that predisposes to this, such as a LVH or a sigmoid septum that makes this more likely to develop. And then there are conditions that will basically reduce the LV cavity size and increase the blood flow to the LVOT, like we see in many of our patients in shock, that can make this develop in someone who does not have a LVOT obstruction at rest. So you can see unrecognized LVOT obstructions or the potential for this to develop can be worsened by many of our initial standard therapies to shock, which is, for example, someone's in septic shock, they're hypotensive, you increase inotropes or increase the amount of pressors they're on. This can increase the contractility, tachycardia, reduce the diastolic filling time, reduce the LV cavity size, and then worsen this drag effect through the LVOT. Then you can develop dynamic LVOT obstruction due to the increased speed of blood through the LVOT, and then worsen your hypotension. And then you could get into the spiral of what some may call pressor refractory shock, and not really know why. You may think they're getting more and more septic, increase the pressors and outcomes more and more, but this is actually worsening the situation. So again, not my images, but I found a nice case study. This is a patient who was septic, then developed a PA arrest. They got ROSC after around giving them 1 liter of fluids. But then he was in refractory shock, escalated doses of multiple pressors and inotropes. And they slow this down, zoom in and slow this down. You can see that the mitral valve is actually hitting or blocking the LVOT during systole. Slide. So something that could be helpful in this case is putting the M mode through the mitral valve. And where the arrows are, you can see that the mitral leaflet is obstructing the LVOT during systole. If you use continuous wave Doppler across the LVOT in the Equal 5 chamber, you may get this classic dagger-shaped late peaking flow, which can again be transient. So in the patient on the right side, this patient does not have this obstructive picture on every beat, but sometimes develops it in that third tracing there with the dagger shape. So this was the same patient from the case earlier. Recognized the dynamic LVOT obstruction. They gave the patient a ton of fluids. And sorry, this is playing. Okay. But basically, if this was playing properly, it's supposed to show that the LVOT obstruction has significantly improved and it's no longer obstructing during systole. So the treatments for this, well, first of all, you have to recognize it and consider it as part of the differential, which is why get into the habit of scanning every patient who's in shock, at least very briefly, to rule this out, is to really fill them up with fluids and slow them down as much as possible. So make sure they're adequately resuscitated, discontinue inotropes or if they're on afterward reducing agents like a nitro drip, stop that. Switch to pure vasopressors if you can, so phenylephrine, vasopressin, things that don't have any beta activity at all. And then some people use beta blockers, which I think is a bit controversial depending on how much beta blocker you want to get to your patient's shock. But if you have something like esmolol that's very quick on-off, you could try it and see if it helps improve your patient's state. So that's basically my assessment or my approach to shock. If we have time, what do we do? Okay. This was a case I saw for a patient a few months ago. I was at a cardiac center in the med-surg ICU, but a center that had interventional cardiologist, cardiac surgeon, and got a call from an outside hospital for requesting transfer for a patient. So this was a 37-year-old woman from home. Not much was known about her medical history because she showed up in extremis. She had a few days of fever, cough, then came in with worsening shortness of breath. In the emerge, she looked quite unwell. She's tachycardic, hypotensive, hypoxic on a non-breathing mask, in respiratory distress, unable to talk, accessory muscle use. This is all described to me from the outside hospital, so never really saw her at this point. And I apologize, I don't have the actual pictures from her case, but something very similar for the X-ray was seen. And she was quickly started on BiPAP, put Artline in, and norepinephrine. And again, this is not her actual vitals, but they described something very similar. So, hypotensive, tachycardic, a breast rate, that's very high. And then once they put the Artline in, they're like, oh, we think she has a pulsus paradoxus. So they put the probe on her, PoCUS, and they see a pericardial effusion and a big and non-collapsing IVC. So this obviously made them think of tamponade and triggered a call to cardiology overnight. The cardiologist actually came in very kindly and attempted a pericardiocentesis, which they said was unsuccessful. I'm not quite sure why, and the procedure was aborted, but didn't cause any harm to the patient. But she was still in shock, still hypotensive, still very hypoxic, still in respiratory distress. So the call was generated to our center as a call for help, and then she was intubated for transfer. And then she got to the ICU I was working at the time. And this is not a vent talk, but really what we're seeing on the ventilator here, again, not hers, but something similar, was very high peak pressures and then expiratory flow limitation, which then made us realize that she was actually having a severe asthma exacerbation. When we listened to her, she was diffusely wheezy, very classic. She ultimately had a flu, and when we found out a bit more history from the family, she did have a history of asthma, had some puffers, but was generally well controlled, not someone who presents very commonly to the hospital. But this flu triggered a severe asthma exacerbation for her. And the pericardial effusion was present, but it was a red herring. It was not the cause of her shock. And the IVC was not reliable because she was both in respiratory distress, had severe bronchospasm and very high hydrothoracic pressures. And she was by that point already on positive ventilation in the form of BiPAP, which can really confound the measurements. And I'm not sure when they initially focused her whether they tried to assess whether the chambers were collapsing or not, whether the RA and RV were collapsing. I'm not sure. But when she got to us, we didn't see any signs of a hemodynamic and pericardial effusion. So this case was a good reminder to me to really always take the PoCUS findings in the clinical context. We can have premature diagnostic closure. We can see things that may be there or may not be there. We could be seeing things that are artifact, or we don't really know what the structure is, and it would lead us to a wrong diagnosis. Always remember the history of the physical exam. I think perhaps if premature diagnostic closure wasn't achieved with the echo probe and she was auscultated earlier on, maybe the clinicians initially would have realized maybe something else is going on apart from this effusion. And then to be very, very careful when, perhaps not in this case, because I don't think this is a case of necessarily discordance, but if there is discordance between your PoCUS exam and the rest of your clinical assessment, to be very careful about our findings and not rely on just the PoCUS findings. And that concludes my presentation. Thank you very much for listening, and I welcome any discussion or comments or your expertise and what you guys do as well in the cardiac setting.